Hey guys, it's Jenny on the block, and I am excited today because I'm here with Summa Health, and I am talking to Dr. Marvin Rossi. Am I saying that right, Dr. Rossi?
You are correct.
Yes, I've done it. So tell me a little bit about who you are. You're at Summa Health, and you have a specialty that I find very interesting. So let's talk about it.
Jenny, thanks first of all for inviting me. I am the director and co-founder of the Summa Health Comprehensive Epilepsy Center here. We are now 2 years and 2 months old. I came from Chicago, spent 30 years at a very large epilepsy center, really trying to understand in a comprehensive manner how to stabilize people who have medication-resistant seizures and how to understand how to work with those individuals who have what we call co-occurring conditions. And those include predominantly mood disorders and other types of disabilities that really can be challenging and are uncommonly addressed at even the largest epilepsy centers.
Wow. Wow. I did not know any of that. So let's talk a little bit about what causes someone to have a seizure, because you hear a lot of things out there on the streets, and I'm sure some of it's true and some of it's very off base. So tell me, what causes someone to have a seizure?
Let me tell you this. So I'm going to answer that directly.
Okay.
And I'd love to talk about what is epilepsy.
Yes.
Okay. So a seizure is really nothing more than many cells and their connections. Imagine a tree with many branches. It's really the branches connecting with other tree branches from other trees that spread these signals across the brain. And the way we think is very, let's just say, singers in a choir that aren't singing the same notes. Doesn't sound pretty.
Right.
A seizure, unfortunately, is the pretty synchrony of singers singing together. So that humming of the same note is what the brain should not be doing. So it's, the fancy term is called synchronizing this activity across the brain. And as we do this, we actually spread this very loud signal downstream across the brain. And sometimes it connects with important centers that are connected with our body, so we can see a seizure, as in a shaking spell, or we just don't do anything. We zone out, we don't absorb information well. And that's what we call an alteration in awareness seizure. And it can be really challenging sometimes to identify these seizures. And let me finish by saying epilepsy is nothing more than two or more seizures separated by a little time, by about a day, or one seizure with the likelihood of a second seizure occurring. And that means there's a spot in the brain, like a tumor, or there's the genetics of an epilepsy. And, you can see this seizure again, unprovoked. Epilepsy is not a disease. It says nothing more but a description of recurrent seizures. The diseases are whatever causes seizures, from strokes to bleeds to the genetics that we can see in the young to degenerative disorders in the elderly. So there are so many causes of epilepsy.
Got it. So it's more, epilepsy is more the recurrence or the likelihood of recurrence?
Perfect. That is the newest definition. You got it.
Yes, I've learned. Okay, so I really thought epilepsy was the disease. So this is something. So could you technically have had a seizure and maybe not even known you had a seizure?
Yes, that is common. There are two big silos or columns or categories of epilepsy. One is the generalized. And it's nothing more than putting wires on our head and we see a little blip on every wire that's not normal. It's not that the epilepsy is coming from everywhere, or the seizure itself. It's coming from a relay center deep in the brain. And often we start in the thalamus, or that relay center. And this is often genetic. And often these young people, often children, teenagers, grow out of that generalized epilepsy. Not always. We have statistics and different types of generalized epilepsy, But that's that one category. The other category is if you put your finger somewhere on the brain, and here's my brain here, you have that epilepsy type, which means if it's from the frontal lobe, the eye would be here. This is called a frontal lobe epilepsy. So it's focal onset, not generalized, frontal lobe, or temporal lobe right here. In fact, our memory center, the most common temporal lobe epilepsy is medial, where our memory centers are. And occipital, the back of the brain. So it depends on where you are. Focal epilepsy can be, let's just say, more challenging or less easily controlled, but certainly controllable. Now, there are about 3.4 million people in the country with epilepsy. Most of them can be controlled without much effort. We have an incredible number of medicines and therapies. About 1 million, though, can be uncontrolled and challenging. And that's where we have to often refer to a comprehensive epilepsy center.
Got it. Got it. Now, this is where I've heard a lot of rumors. So you can clear this up for me. If you see someone having a seizure, how do you help a person who's having a seizure?
I think this is such an important question because we always want to do something, or unfortunately, some people don't want anything to do with that person because they're afraid to approach them.
Yeah.
So I think the most important thing to do is actually clear the area around that person if they end up falling on the ground. Certainly, if you happen to notice somebody in the midst of an early onset seizure, you may want to help them to sit or actually get to the ground, in a gentle way. And you really do want to give people space. You don't want to get close to their mouth. Myth, do not put your fingers or an object in the mouth.
I've heard a lot of put the wallet in the mouth, put fingers in the mouth. I'm like, I don't think you should put things in people's mouths. It doesn't sound safe.
Correct. That is correct. So that's so important. And if the patient actually, well, in my world, the patient, but if that individual is going to start spreading that seizure activity through the brain and hits the movement centers or the motor areas, you end up seeing this sort of back and forth movement. And that's the clonic activity we often see in a convulsion or convulsive seizure. You then lie the person on their side, okay? So, because the risk of aspiration is great. So still give them space. If they start convulsing, you want to do that so they're not going to aspirate or swallow their spit or vomit if they happen to do that, or blood, if they bite their tongue.
Okay. All right.
And then you really should, if there's a caregiver nearby, they may want to, direct you, because sometimes these individuals may not want 911 called, believe it or not. But if your gut feeling is saying to you, this person is hurting themselves, you just dial 911, and that helps right there. You can open the jacket if there is one. Just again, clear the air a bit. Let them don't congregate around that person. I also want to say that the standard convulsion, we'll say, lasts between 30 seconds and 3 minutes, typically about 90 seconds. And there are many caveats to that, but post-seizure, and that's the post-ictal period, that person is either sleepy or, if not, confused and combative. And that's probably the most dangerous time, where you're really in a place where you want to make sure they're safe. And as far as you go, you're safe as well. So you're backing away and you're trying to, help this person, maybe redirect them, but don't get too close and don't restrain them. I've unfortunately watched security guards sit on people and worry about, them injuring themselves, really, but they're not doing them a service by getting too close to them that way. Certainly, you have to be careful about the environment, especially if they're out in the public, the open, where they're in the street or something like that. You really want to be cautious about helping them protect themselves. And that's it.
Question about I have a friend who suffers from seizures, and She's told me before she feels it coming. Do a lot of people feel a seizure before it hits them? Or is it for some people, it's a total surprise, they didn't see it coming? And does it vary by person?
Yes, yes, and yes. You know,
Okay.
the standard, typically, and not always, there are always exceptions. The generalized epilepsies, we say the person doesn't have that warning sign. But I'm here to say that some people with generalized seizures do have a funny, nondescript feeling. You know, they're just not feeling right, or they're zoning out for a few seconds, like they feel something's coming on. But typically, they don't have that crisp warning sign. And that warning sign, by the way, is the beginning of the seizure. It's not that, hey, I think a seizure's coming. It's a seizure's happening now, and I need to get to a safe place. So if somebody does have that warning sign, this is more typically at the beginning of a focal onset epilepsy. And depending on what that feeling is, you can even come close to localizing where it starts. You know, so we have a feeling for what types of behavior or internal sense of the onset is localizing for the medial temporal region where the memory center is, or, you know, more lateral here. We say this is the memory center, more lateral in the temporal lobe here. So just by listening and watching that individual, you can probably get a feeling for where that focal onset seizure is coming from. The important part is if they do have that warning sign, you know, they try often to get to someplace safe, and you know, and hopefully we can see this seizure end. And again, contrary to some belief, the person who's suffering from the disorder may have some ability to get beyond this spell or prevent it from progressing, but that's often not the case.
Got it. So how are patients with epilepsy and NES treated?
Yeah, so you brought up NES. So to define NES, you know, that's non-epileptic seizure. And I don't want to confuse everyone. There are the epileptic seizures, and seizure just means, you know, grabbed and shaken. And, you know, whether it's by a divine power or not, you know, there's this history of where that definition came from, but it doesn't mean it's clearly cells firing together when we use the word seizure. So the epileptic seizure is what we've just talked about. But non-epileptic spells can be a number of things. And one of the most common type of non-epileptic seizures is the psychogenic non-epileptic seizures, so PNES. And we have to be able to, you know, separate the two, and it can often be very challenging because some people who really don't give you that simple, straightforward look of a convulsion, and who are moving around rapidly or oscillating or even spinning, and they look strange, you know, actually could be experiencing a seizure. At the same time, we have to consider, is that truly a seizure, or is it a spell, which is really, for many reasons, and sort of demonstration of remote trauma, psychotrauma, and it's coming out in a subconscious way as this type of spell that looks like an epileptic seizure. And there are treatments for that type of spell, or PNES, which typically do not include medicines. And so we have to be very careful how to differentiate the two. And I can tell you, even for the experts, this can be challenging.
Yeah. Yeah. I mean, it definitely sounds like this, it can be hard to tell the difference, even if you are an expert. So, what type of epilepsy services do you have at Summa Health? I know you moved here from Chicago. Summa is a great place to be. And I know there's some technology that probably brought you here as well. So what do you guys have?
Thank you for asking that, Jenny. You know, a comprehensive epilepsy center has 5 pillars to keep this type of initiative really wrapping around all the needs of the individuals who come through the doors of a comprehensive epilepsy center. The first is medications. You want access to all the meds, including medication trials. And we, after 2 years, have access to all of those meds. And we have 2 new drug trials, which I think is very exciting. And 2, we want when medications fail, or in addition to medications, there are specialized diets. And these epilepsy diets can actually work up to 6 times better than a medicine.
Wow.
The catch here is that you have to be adherent to the diet. And there are several. And so we have a formal epilepsy diet clinic. We have a dietitian who works with our patients and the clinician who works with them at the same time. So I think this is an uncommon thing to see. We have many children transitioning to adult care from the area here, in particular Akron Children's Medical Center, and some of them are on certain diets that help their seizures, and we can accommodate those children. The third pillar is a big one, and I don't want to save that one for last, but it's behavioral health, and I mentioned some of that. Yeah. And so we have the Juvie Behavioral Health Center here, which was recently opened, but at the same time we have what we call the PNES clinic, which is uncommon in the state of Ohio. In fact, in Chicago, there was only one clear-cut clinic for adults that worked with those individuals. And we have a dedicated psychotherapist, social worker, and the director, Dr. Craig Hansen, who had talked previously about PNES, actually has really pioneered this initiative, that one great pillar. The fourth pillar is what we call stimulation therapies. And again, stimulation, typically from implantable devices, can work many times better than medicines. And these are medicines that after 2 have failed to work, that is, keep someone seizure free, and I will argue for about 1.5 years, that patient is medication resistant. A 3rd, 4th, 5th may help, but the probability is lower. The most common stimulation device is what's called the vagus nerve stimulator, and it's implanted in the left chest. Here's an example. And it comes from the company LivaNova. It was the first stimulation device to be approved in the country in 1997. And it goes in the left chest area underneath the skin and a wire going up to the neck. And we tune it to basically send very low level stimulation to the brain every several minutes. And after a period of months to years, those brain cell trees are remodeled. And that remodeling, as we see more branches on these brain cell trees, actually inhibit seizures from breaking through. They actually stabilize seizure networks. And I think that's dramatic. And from that experience, we then started a trial in 2004 called the responsive neural stimulation trial. So again, this is the VNS, vagus nerve stimulator. This is the responsive neural stimulator that actually is a skull-based device. It's actually an implantable electroencephalogram, or EEG, that goes into the skull, replaces a bit of the bone, and there are 2 leads or wires that go into the circuit. It connects with the circuit that we identify, and we do this well at Summa Health, as in a weather map, looking at the storm onset, that seizure onset zone. And we can record the onset of our seizures and then stimulate and abort, and also remodel the brain over time. And that data can be uploaded from the person's home to a database that we can then access anywhere in the world. And it helps us tune that patient's seizures. The last pillar is resection. So that is, we take out a scar, an abnormal area in the brain. And I think that's critical. It's a more standard resective surgery, we call it, that often helps our patients in a big way. And the chance of seizure freedom is great, much greater than those people who have failed therapies. Okay.
Got it. Wow. I mean, a lot of that technology, is some of that really new? Like I knew about the medication. I knew about the resectioning. I've heard about that before, but these implants, those are pretty cool.
The great thing about technology is we all know with our phones and computers how much they develop in such short periods of time. So the VNS, even though it was approved by the FDA in 1997, new models are coming out regularly. And the newest model about to be released actually can be remotely programmed. And I think that's important in the home. And by the way, we are able to do that now here, but it's not on label. So we just figured out a way to do that. And we're the first to do it, but very soon it will be FDA approved for everyone. And then the RNS even though it went into trials in 2004, it was approved in 2013. And it really was meant for the largest centers to implant. So we didn't see this a lot. And there were only 200 centers in the country like this that can do this sort of surgery. Mm-hmm. And we are able to do this type of surgery now. And the FDA has just recently relaxed that requirement. So now that other well-equipped centers, but not at that highest level designation, can implant. So this may not be so readily accessible to people as far as the experience with it, but that is changing, as we speak here. So we'll see more of those implanted over the next year or so.
Awesome. Well, it sounds like Summa Health has a lot going on when it comes to treating those with seizures. And I want to thank you so much, Dr. Rossi, for being here. If you guys want more information, you can always log on to summahealth.org/epilepsy. Again, it's summahealth.org/epilepsy. And thank you again for being here. I really learned a lot today.
Thank you, Jenny. It was a pleasure.